So hello, we're going to go ahead and get started. And then we can, because I'm really excited for this session. I'm excited for all the sessions at this meeting. This is a great meeting. The energy has been tremendous. This session is on new therapies and devices for early career practitioners. And I'm excited to have an expert panel with two somewhat more seasoned presenters and two earlier career presenters, which is very much in the spirit of this sort of thing. And I thought we have about 12 people online, and then we have a bunch of people in the room. So I just wanted to get a sense of who was in the room and kind of also get a sense from the room. Also, if you have particular questions, so if you're on Zoom, if you want to stick them in the chat, I can see that. Or if you're here in the room, if you want to let us know, like, if there's one thing in particular you're hoping to learn in the next 60 minutes, please let us know that so we can make sure to cover it. So of the people in the room, how many are pediatricians? Raise your hands. How many adult docs? Okay. And how many have been in their faculty position for more than 10 years? I would be in that group. Okay. How many 0 to 10 years, like less than 10 years, but early career faculty? Any fellows in the room? Any medical students in the room? Okay. And anybody who doesn't fit into something like that. So non-faculty staff. Great. Great. Okay. And is there anything in particular people are hoping to hear here? We can always have questions at the end too, but I want to make sure. Okay. So with that, I will not take further time from the presenters. I'm Linda DiMeglio, by the way. I'm the division chief in Indiana. Been in this space for a while. I'll just say, because I've asked all my presenters to say this up front, I wanted to explain to people why I have people explain what got them passionate about diabetes and why they wanted to be here. So I'll just say that my aunt had type 1 diabetes. So I watched her manage her diabetes when I was a kid. I thought it was kind of interesting. And then I watched her very sadly have multiple complications. And she died when I was in my residency. And then in residency, I got we took care of kids in DKA on the floor if they were in mild DKA. And I loved the spreadsheets and all the numbers. And I thought it was really, and then the morning, like you'd manage this kid all night long. And what was the fluid deficit? And then in the morning, the endocrinologist would come in and say, switch them over to sub-Q insulin. And I'd be like, oh, and I like the education and the kind of chronic. I would prefer to cure type 1 diabetes and never have to do this ever again. But on the other hand, I like the chronic nature of the care that I can provide, and that I see the kids every 3 to 4 months and I get to know them and I get to know the families and that support. And I'm like Todd, also a passionate camp person. We never camped as kids. So now I do a diabetes camp, and that's been a lot of fun. So with that, I will turn things over to Todd Alonso from the Barbara Davis Center for the first talk.
Thanks, Linda. I'm going to slide over here. My name's Todd Alonso. I'm a pediatric endocrinologist in Denver, Colorado, and I've been in my role for 10 years and 3 months. So I got to raise my hand in the seasoned group, that and the gray hair. I guess that's why I fall in that group now. And then, okay, I got it. I don't want to upgrade my toolbar anymore. Is there a way to get that to clear? There we go. All right. And what got me into the job, it's a long story that involves a free lunch. If I would have known where I would have been, I would have gotten here differently. I think it's the first thing I'd say, but really, I knew that I wanted to have long-term relationships with my patients. And, there's something about being able to walk in the room when the sun comes up and be able to tell people it's going to be okay, which is what we get to say most of the time. And that's a part of the job that I just really fell in love with as a resident, as a medical student, before I chose to go into fellowship. So really happy to be where I am. And I'm going to give credit here really to everybody else on this slide before me. I'm the guy presenting, but I played a very, very small role in helping Kimber and the team put this together. So Kimber and Andrea and Peter and Briggs are and Taylor, so I have to double check. Those are our physicians on our prevention team at BDC. Lexi is our really awesome nurse on that team. Holly and Paige are psychologists, and then Becca's our QI coordinator. She's also here at the meeting with me today. So we're part of the teplizumab studies, multiple studies going on, and we have a prevention team. We're a trial net site. We have the ASK screening program. And when teplizumab was approved last fall, we put together an early T1D clinic thinking that we need to do this with some structure. Structure is always a good thing. And then to advance. All right, I pushed all the buttons. Anton, can you help me? I'm out of buttons. Anyway, I'm just going to keep talking here. So we put this clinic together on Friday mornings with the idea that we would have a dedicated team of people who know about teplizumab and how to counsel patients on teplizumab, and then can, evaluate, thank you, patients that have come to us. Awesome, thank you, on through screening programs. So as you guys know, individuals with islet autoimmunity and concern for dysglycemia need to have some metabolic staging. And so these are the things that we do in the clinic. And we've had to figure out, how do you do an OGTT? You're not going to get paid for it if you do a point of care test. Then we also have a health and behavior assessment, which is why we have our psychologists working together with us on the team. We get the metabolic staging results in the clinic. And then our team has a conversation about using teplizumab, which we prescribe and initiate a PA. Sounds really easy. It's not. And so using ADA staging criteria, about 3/4 of our patients who came into this clinic were stage 2, about 20% were stage 1, and then 1, as they were coming into clinic, was diagnosed with stage 3. And of those with stage 2, we've successfully infused 6 of them. And as you know, patients with stage 1 are not currently eligible for teplizumab therapy, but they might be eligible for other trials. And these are the people to talk to. They run those trials on our team, and so they can counsel our patients on what they may be eligible for. And so, as I mentioned, one patient initially classified, there was an additional patient that was classified as 2 initially, and before we could infuse, that patient progressed to stage 3 and needed to be on insulin. And then we had 11 patients that have been, that are in stage 2, they've been authorized for treatment, and we're just working on scheduling, and 5 more that are under review. And then this, I think, graph really tells the most important part of the story. So so each patient is a row. This is patient level. These are rows. A1C, fasting glucose, OGTT. I know that's tough to see from the back of the room. And then CGM's on the right. So that's not part of the staging criteria. But you can see green would be stage 1, yellow would be stage 2, and red would be stage 3. And so how do you categorize people? What are you using? You can see fasting glucose. A lot of these people fell into stage 1, but when we use A1C, we had more of them fall into stage 2, and we use OGTTs. We actually had a few that hadn't been stage 3, that on the OGTT, they failed and were stage 3. And then we have, we're looking at CGM time greater than 140, and you can see, or you probably can't see because this is very small. Basically, there's a wide range between, I think 6% is the lowest number up there, all the way up to 63% timing range. There's a lot of variability when you bring these patients in and assess them. So for patients who received treatment, we do follow-up visits 1 month afterwards, and then 6 months afterwards, and we do intermittent CGM wear. And for patients that are stage 1 that didn't qualify, we do every 6 months because we want them to follow up. And what we've learned from TrialNet and other prevention studies is when you have somebody who's antibody positive, if you don't bring them back and remind them of diabetes symptoms, their DKA risk approaches the general population risk over time. So you don't let them disappear. You keep them under your nose, even if they're not receiving treatment. So conclusions, individuals attending this clinic tolerated the metabolic staging per ADA guidelines. We were able to roll that out and did that well. We've successfully treated 6 patients. And then that's the next slide there. So I wanted to go quick enough because I know there's a lot of questions, and I've received some on email ahead of this. Did you guys have any questions about what we have? Yeah, we'll just pass the mic. I can walk.
Thank you so much. So, I worry that our butterfly net has a lot of holes in it sometimes, and I guess I'm curious your take on screening the general population. And so looking for antibody screening and so on, because there are those patients that it's so hard to find in the right stage to kind of put them through trials and so on. So I was curious what your thoughts were on screening.
So I think we're moving more towards universal screening. The ASK study is anybody in Colorado and beyond can be enrolled in ASK now. And so we have more and more patients coming in. I know JDRF has a program. Some patients who screen positive in some programs don't screen positive with antibodies when we repeat them in our lab. So just making sure that we've got, which lab are we using? We really trust our antibody lab in-house. The stage 2 window is probably a lot shorter than the stage 1 window. But we can treat people in stage 2. And so when you catch them in stage 1, you need to surveil them. And so having some kind of clinic structure to bring them back, even if they're short visits or maybe telemedicine visits, especially when it's straightforward. But you're right. I think that we're going to miss a lot of the population. And then as we ramp up metabolic screening, who are the privileged people who are going to get screened? who are the privileged people who are going to be able to come in for 14 days straight for an infusion, and you're going to have a parent sit with them in the room. And then if you serve a large geography, I mean, for some people that would mean staying in a hotel for 14 days, which again, you know, that's a big privilege. And we've had people from across the state who were eligible for this drug, but said, I'm not going to do that because I can't travel to Denver and stay there for 2 weeks. So I think that it would be really wonderful to prevent and ultimately cure type 1 diabetes. But this type of therapy here it's just the beginning. It's going to be really, really hard for us to make to make the impact that we know that we want to make. Yeah. So it's a start.
Great. Thanks, Todd. So my question was, were you using the CGM with the glucose greater than 140 as a staging criteria, or was that just investigational? From the adult perspective, when we look at normative data for adults, many of them have got CGM post-meal glucose is above 140. So I was just wondering if you were using that data, because then you would differently classify them, and there was maybe be people that we stage 3 disease and wouldn't benefit from the TZIELD.
Team is primarily interested from just an academic standpoint, like what are we going to use? And these people are under our nose. Let's use it now and just collect that data discreetly. But you know, for those of us who have looked at CGM data on somebody whose shoe is about to drop, you know, when do you start the glargine? And the CGM data is really, really helpful for that, because they can fail an OGTT test in your clinic and then not have hyperglycemia for the next 2 years at home. And I've had those patients along the way. So I think these data are going to evolve, and we probably ought to be recording this now. Thank you.
Hi, Todd. Carla from Rady Children's Hospital, San Diego. Thank you so much. And I'm sorry, my question is so like primitive, because you're so ahead of the game in this comparing to everybody else. But now that this is a reality and it's patient care, in many sites or other smaller places are not part of programs. So we are trying to put together, how would you do that? First of all, you're talking to start with something, right? We start with the relatives, right? The first degree relatives, like from our patients. What's the first step? Because we cannot order labs for people that we're not treating, right? That are not our kids. So how do you, first is the conversation. You know, I think it's a sensitive conversation. You have to be very careful when you share that information and all the possibility. And who should do that screening if you're starting from without having a program, and to move forward from there.
We're super privileged in Colorado with screening. We've had the ASK program for about 5 or 6 years. And every time I'm on call, I get this question where a pediatrician calls me and says, I have a kid whose mother is really worried about diabetes because it was a classmate diagnosed, or something like that, where they don't have a first degree relative, or maybe they have symptoms. And you can think, well, I could bring them into clinic as a rule out. I could just bring them in as a patient, see you as a new patient. That's one option. But, you know, and then how long is that visit, and how many of my new onset slots am I taking for that? And where do I see them? This clinic is a place for that. So having a Friday morning dedicated to this is where we try to put those patients, but you don't want to have unused spots. Oh, you don't have one because there isn't one. That's a whole other conversation. So this is a huge question. Joyce, are you here? Who else is on the data governance committee? This is a data question. So you can use pre-diabetes, which is a terrible code. So if you go into if you're using Epic, and if you load your codes from IMO, that's Intelligent Medical Objects, the IMO codes are created to map to ICD-10 codes. And our group, this is Briggs who did this work, met with the IMO people, because we started with our medical record locally. And we said, we need you to create new codes, custom codes for us, because we're going to have a lot of these patients. You're going to have to help us deal with this. And they said, and Briggs has got a 50-slide deck about like why pre-diabetes is a bad idea and why we need something else. So IMO created codes. So if you guys have gotten loads from IMO in the last couple of years, you can ask your IT group, can I just find stage 1 and stage 2? Do those exist? And that's how we have them coded. And I can send you an email with the text and the names. So does that exist? She has also met with the ICD-10 committee, and they have a vote coming up in the spring. And if it passes muster, then ICD-10 will create codes for stage 1 and stage 2 type 1 diabetes, which deserve codes. And if we call them type 1 diabetes, it's going to screw up our data in the database. And so I would suggest everybody right now is in your data fields, you should have a stage 1 diagnosis date, a stage 2 diagnosis date, and a regular diabetes diagnosis date, like a T1D diagnosis date. And these need to be separate fields. You need to maintain them and don't overwrite them. However, you record that now, because these data are going to be important in the future. But we don't have ICD-10 codes yet. I think we have maybe a minute left. Yeah, I'll come back.
Thank you. So I have several questions, but I'll ask one. So who prescribes the teplizumab? Who does the follow-up? Who gets called if there is a side effect? Are you in the clinic taking that responsibility, or do you get, I don't know, the pediatric endocrinologist that refers them to you take that responsibility?
That was more than one question. Just kidding. No, those are the best questions. So I mean, if I didn't say it already enough, just Kimber Simmons has led this for our team. And she's basically like, you guys can call me on my cell anytime. So Kimber and Peter and Andrea, Taylor and Briggs staff that clinic, and they see these patients, they do the prescriptions, and I help them program the Epic stuff around that, but they take the phone calls and the follow-up. Yeah.
Yeah, thank you very much. Thanks, Todd, for an excellent talk. I'll also just mention in this room, as there's many of us here from TrialNet, the TrialNet also does have an open door policy, and anybody that screens positive, whether or not they're a relative, is welcome to come and get repeat antibody testing and initial metabolic assessment through TrialNet. So just, you have to get to a TrialNet center that's offering monitoring, but that's also free and confidential, and we do that all the time. So then if they confirm, then if they want teplizumab, they can go there. So with things, I'll turn it over to Korey Hood, who's a professor at Stanford, to take us through DiabetesWise Pro, but start by telling us briefly about your, what informed your path.
Yeah, well, thanks for the opportunity to talk. And one of the interesting things that kind of following on from the last presentation was that my dissertation topic, which is now 20 couple of years ago, was focused on newborn genetic screening and type 1 diabetes. And I fell into that a little bit because I was at the University of Florida and working on my PhD. And then I had all the classic symptoms of type 1. And so I was diagnosed at 24 and have been just deeply embedded in the diabetes world for the last 25 years or so. But part of the reason that I say that is that I came into my PhD program thinking I was really interested in the intersection between health and the psychology and behavior and emotion. So that was the part that intrigued me. And then I think it took a little while to figure out what exactly I was interested in. And I just kind of fell into diabetes from a research perspective, and then became more involved because I had a personal connection to it. So I think that maybe I don't know that we're offering bits of advice, but I do think that if you don't know exactly why you're doing something, that's okay. And continue to follow some of those different paths and investigate those. And you may find something that's really salient to you as you move along. So as Linda mentioned, I'm currently at Stanford University. I've been there for about 9 years. And one of the areas that we've really focused on, particularly through collaborations with a number of, some of kind of the pioneers like Bruce Buckingham and others in terms of diabetes technology and automated insulin delivery, is we've tried to give better tools to people with diabetes and their healthcare professionals to navigate all that's available to them in terms of diabetes devices. And so I'm going to talk about DiabetesWise Pro, which is the healthcare professional version. And as you can see on the slide, and I'll stand back so you can see better, but this work is funded by the Helmsley Charitable Trust through several grants that we've received from them. And then you can see our partners, Upshift, which is focused on the web design and development, and then HealthMade, our partner on the design side. So our journey was, if you see down there, and number one, you can tell that, as I just mentioned, we identified what we thought was the problem, which was there really wasn't a free unbiased, unbranded platform where you could compare and contrast devices. If you're interested in looking at a couple of different CGMs, or if you're looking at different pump options, you couldn't side by side do that in an easy way. You might have to have, 4 pages open and then go back and forth and think through it. And so we wanted to create a tool that you could do that pretty easily. We explored a lot of different options. We talked to a lot of different people. We talked to people with diabetes, their caregivers, their providers. We talked to other kind of stakeholders. And we landed on DiabetesWise, and we created both the person-facing one, which was we released in 2019, and then the healthcare provider version, which we released in, I think, more full form in February of last year. One of the things that we did with DiabetesWise, so DiabetesWise is the patient or the person-facing version, was we created a checkup tool, and then we tested to see how well it works. And so we condensed over 300 questions into just 5 items that we could ask people that might give us an indication of what they might have a preference for based on, their priorities, their lifestyle, things that they want out of a diabetes device. And what we found was that, and this is a study that we published in Journal of Diabetes, which is where all of these abstracts are now published. But this was a paper we published earlier this year where we followed 458 people with insulin requiring diabetes. So 75% with type 1, 25% with type 2, but all insulin requiring, not on devices on a regular basis. And so only 3% of the people that came into this study were even using CGM on a somewhat infrequent basis. And one of the things that we found was that across 3 months, just by using the tool, and we could track all of their activity because we had some guardrails around it at that time, and that a large percentage of them, by the end of the study, were initiating conversations with their providers about devices. So they may not have moved much further than that, but they were starting to have conversations. And there were a third of them that either had a prescription or a new device that they'd started just in 3 months. And so a relatively low touch intervention. This digital platform really helped people move along. But we also found that the people who were using this were people with fewer diabetes resources, people who are on meter injections. It's partly biased by the people that came into the study, but also a lot of people receiving their diabetes care, all adults receiving from primary care versus specialty care. And I think that you've probably heard that pretty consistently. This is where most adults with diabetes are getting their care, is not in specialty clinics. And so trying to find places for them to access this information. And so what we thought about and I think maybe what's most relevant to this group as we're talking about these different devices and what it can, how DiabetesWise Pro can help you as a healthcare professional. We think that when you're taking care of people with diabetes, the DiabetesWise Pro can improve matching to devices. So it'll give you a little better sense of what the person is asking for in terms of their priorities and preferences based on their responses. We also wanted to streamline the prescription process because we know that's a real pain point. It's more than a pain point. I don't even know what you call, whatever is above the pain point. But what we heard from a lot of people, that a lot of different healthcare providers, whether you're in primary care, family medicine, in a specialty clinic, you want to know if the device is going to be covered, and you want to know if it's going to need prior auth. And then there's a bunch of other things after that. But those are really the 2 most pressing things in your mind about what to do. And so we wanted to make that easier. And we wanted to have real payer data that feeds into our site so that people can understand what's going on currently. So I'm just going to highlight a few of the different features here. If you go to DiabetesWise Pro, you can browse different devices. So you can put it in, you can search all of them that we know of are on there. And we constantly update it, especially as things become FDA approved. Even if they're not available to people yet, if they're FDA approved and there's momentum behind them, we're going to have them on the website. So you can browse for different devices. One of the, I think, popular sections, particularly on the person with diabetes side and caregivers and family member side, is understanding a little bit about what people experience. So what are their stories? What are some of the real life experiences that they have? And so we have a section called Wisdom, where you can hear stories, and people talk a lot about their experiences with trying different devices, what led them to try it, and then what led them to stop using it. What were the frustrations? Sometimes it's alarms, sometimes it's the way it feels in the body, sometimes it's that somebody made a comment. But people go through a lot of kind of their own like personal journeys whenever they're thinking about these different devices. And I think often when we see them in a clinical setting, we're getting just a very tip of the iceberg about what's going on in their mind about devices. But there's probably a lot more to it than what you hear. One of the more popular parts of the site, and we also have this on the patient side or the person side, is a comparison function. So you can drop down and compare different CGMs, different pumps, different automated insulin delivery systems. And then you can compare it on the different components. You can compare it on, here you can see, it's a little bit hard to read, but active lifestyle. I can't read it. Avoiding highs and lows. So you have the option to also drop down what the person in front of you or the person that you're thinking about, patient that you saw yesterday, what they said to you about their priorities for potentially using a device. And if they don't know, then this is also a tool for education. And then as you can dive deeper into whatever the device was that you settled on, or you maybe settled on a couple of them, but this will give you more information. And these are just examples. We don't have funding from Dexcom or any of the other device companies. It's all entirely from the Helmsley Charitable Trust in Stanford. And so, but this is just an example here, but it goes through all the different things that you need and gives you information on how to go next. And then if you want to help with a prescription, you just need just 4 inputs. You need to select the device type that you want, the state that you're in, the plan type, and the payer information. And so it's really simple. And we've done all the back end work because we know how much of a pain point this is, so that then you'll get an output that provides the summary of the coverage. So this is an example from California. Anthem in California has Dexcom G6 on their formulary. It's distributed by this provider. And one of the things that we've noticed over the last couple of years, especially, is there's been movement to pharmacy away from DME, not across all devices, but there's certainly been more trends in that direction. And so because we're updating our database with payer data, real payer claims every month, you're going to get a very accurate view of what the current landscape is. And then if you want to go into more information, it's got both the pharmacy and the DME billing codes. It's got the different components. You can link to or connect to the CMN formats that might be needed by different companies. We don't do that for you, but you can link to all of this. And then also, if you want help on the billing side, there's all these payer links. Again, we don't necessarily consolidate this, but we provide this. But the part that we do make easy, and I think has streamlined the process, is to know, one, is it covered, and is prior authorization necessary? So to quickly summarize, DiabetesWise Pro was built to inform and improve the prescription process for healthcare providers taking care of people with diabetes. As I mentioned, some of the different features include the device library, the comparison tool, prescription support. I talked about Wisdom, experiencing some of the other people's stories about this. And again, mentioned supported by Helmsley, so we can be free, unbranded, and really untethered to device manufacturers, which I think helps as we try to navigate this. I would say that, our main bias is that we need to get more people on devices by increasing access and awareness. Not everybody's going to want to use them. Not everybody is going to have the same kind of benefit, but most people don't have access, and a number of people aren't aware of what's available to them. And so part of what we want to do is to increase access and awareness as part of this work. So I'll stop there. Any questions?
This is really fantastic. The insurance checker thing that you mentioned, where exactly is that on the site? I was trying to find that, like matching insurance against device.
I can show you. Well, you're on JDRF's website, so not that they don't do good work, but no, there it is. So if you click on the provider one up on the top, but so you have to go to pro.diabeteswise.org, and then you'll see prescription up on the top right side, and you click there, it'll take you right to the tool. The tool is we pay a company called Policy Reporter that has contracts with all these different payers to pull in all of the data. And so then we make it into something that's meaningful. So other questions? All right, thank you.
Thank you. Okay, so we're going to shift a little bit over from program development to kind of nuts and bolts of diabetes management. And so Dr. O'Malley from the Ichan School of Medicine at Mount Sinai will talk to us about insulin and rescue medications.
Hello. Yeah, so I'm Grenye O'Malley. So I really became passionate about type 1 diabetes, really my fellowship, because of clinical research. But then another hat that I have is also being the wellness champion for my fellows. And so that's like a lot of what I'm incorporating into this is how QI not only helps our patients, but also, especially as early career, can help our quality of life as well. So that's what I'm going to keep harking back to. And I actually heard about DiabetesWise Pro this morning, and I've already told my fellows about it during lunch. So I'm definitely going to incorporate that into their workflow. All right. So I get research support. So I'm going to go over, going over insulin, and I'm going to include devices in that, rescue medications, and then really focusing on how we can use QI and using your team. So I think the major new things about insulins right now is really the explosion of generic pens, which is probably great for our healthcare system bottom line, but really annoying for our workflow. So this picture on the side is actually a dot phrase that I have that I probably use more than any other dot phrase I have, where I can actually, pull up a list of all the insulin pens and I ask people to point to what they're on, which has saved me so many times realizing that they're on Basaglar and Semglee or something like that. But just putting the 20 minutes into Googling all the pictures and making this for yourself it saves a lot of time. Also streamlining communication with pharmacies. Some pharmacies will actually allow you to, put in the comments that which other things you're okay with. In your EMRs, like in Epic, you can do preference lists where you can actually have some of this pre-pended. Like I have ones for type 1 diabetes where I already have almost all the words in. I just have to put in the units. I already have in their diagnosis code if they're for Medicare patients. All those little things put on your calendar to optimize your Epic or your EMR system, because you'll never do it unless you really set the time for it. Another thing that's new in the past couple of years is the cost caps for Medicare. And one thing that I do want to mention for that, for your patients, especially with type 2, is that the insulin cost caps, it also applies to combination insulins with GLP-1s. So if you have a patient on insulin and a GLP-1, you can save them a lot of money that way. And then another thing that I started doing a couple years ago that has probably made the biggest impact on my January, because I used to hate January as an endocrinologist, is now every new patient I see with type 1 diabetes, I ask them what insulin they're on and what insulins they've been on in the past. And are you okay with me switching it in January if your insurance asked me to? And suddenly hate January anymore. I have it in my notes. I know which ones to resend and which patients to do a prior auth for. And I think my support staff also appreciates this. The other thing is to always think outside the pen. And into connected pens. There's a few presentations at this meeting about our work doing increasing equitable access to connected pens, such as InPen. This is, if you can incorporate it into your workflow, suddenly having actually how much people are taking and when and connected to their CGM, it improves visits so much. But also think about the opposite type of patient who might be not tech savvy at all. The Novo Echo has a timer that just starts every time they take an injection. So a patient who can't remember if they took their insulin and then their loved one gets there, at night and wants to check on them, they could just look at the timer and see, okay, has it been less than 24 hours? And then also thinking about things that, we often forget about, and in our insurance headaches, like inhaled insulin or insulin patches. We don't always have to be just pens and pumps. And then also putting like pharma to work. This is their job, is to sell things. And it was really in one of a QI project that we were doing through the exchange where we had so many sites and people were describing what their reps did. And the people in New York were like, our reps don't offer to do any of this. And so then we started just putting things more on the pharma reps to do more training, to do more looking into which pharmacy it should go to. And then they started doing it. So, put the onus on other people sometimes. So, and then of course, the biggest thing in the recent years, as far as insulins, would be our hybrid closed loop technologies. So I'm just going to give a summary. You could go to DiabetesWise for a more in-depth comparison. So I was asked just to highlight mainly the biggest differences between the systems. So for Control IQ, we have the target of 112 to 160. In sleep mode, it's a tighter target. There's no automated boluses during sleep mode. So some people do use sleep mode 24 hours, but that is a trade-off. In Medtronic, the 670 and 770 use a target of 120, but the 780 will have 110 to 120 choices. Omnipod 5 has choices between 110 and 150. And then the iLet is going to always be 120 for their usual. But there is the option for like lower or higher target, which is 110 and 130. And really the thing to focus on is what, as a provider, like which parts of is the algorithm actually going to take into account, right? So for Control IQ, they do take into account basal rates in the algorithm, but the algorithm can change the background basal rate from anywhere from 0 to 4 times what you preset it as. So little changes like a 0.5 unit change is probably going to have no clinical impact. And then the biggest impact will be carb ratios, and then sensitivity factors are taken into account for the automated boluses. Unlike Medtronic, which doesn't account into your basal rates at all, does not take into sensitivity factors. So it's really going to be carb ratios and then 4 boluses, the active insulin time. Omnipod 5 will also take into account the correction factors a little bit more than Medtronic does. And then the iLet, you don't put in anything. It's just weight. And then there's also, you can put in when they sleep. So what you can also focus on then is the user inputs. So for Tandem, Medtronic, and Omnipod 5, dedicating that time to focusing on carb counting, and also the timing of boluses. iLet won't have carb counting, but they have the smaller, usual, and larger. So there you can, focus on timing of boluses, and also in the early stages, especially consistency of meals to allow the system to learn. Tandem, Medtronic, and Omnipod all have their version of exercise or hypoglycemia protection mode. iLet just kind of takes care of that, no input there. And then Tandem has phone boluses. Omnipod 5 just like 2 weeks ago, I think, had the iOS systems approved. And remember, Medtronic is the only sensor that will then have the calibrations. And then also working into your workflows, for the systems that don't rely on your basal rates. You might not be looking at them as often, but you want to remember to be making, backup changes. If someone's requirements have really changed, you don't want them going back to, years ago basal rates when their sensor goes down. And the iLet has a really convenient feature where it will tell you the average dosing so that you can be guided for if they need to switch to backup pens. All right. So, and then with these devices, this is a really great QI and equity opportunities to check on who you're prescribing to. You can run reports in your EMRs just on your own patients to see, what your breakdown of ethnicity is or other things to, to just check on yourself. And then really streamline how to offer technology. If you're always just kind of on the fly, looking up websites and everything, that's going to introduce bias in how you're offering it and also put more burden on yourself. So really thinking about your team, like who's discussing the options, companies usually do the first trainings, but a lot of people need more trainings than they offer. Who's doing that? One thing that I think often endocrinology fellows don't get a lot of is all the nuances of like infusion sets, some people get that from the company. Some people seem to not get that advice at all. So knowing who in your team can really like take ownership of that. And then for rescue medications, there's now a lot of different options for glucagon, vial and syringe, auto injectors, and also nasal powders. One caveat is that they come in 1 and 2 packs. So when you get asked for a prior auth, sometimes you're denied and they don't tell you that it's because they didn't want to do a 2-pack. So don't always assume that you have to go back to old fashioned things. It could just be how you prescribed it. So that's another thing to streamline. And then make sure, this is another great QI opportunity, make sure that you have them before they need them. And tailor training, right? These are going to be very, very different medications to administer, and it should really be their family member, their roommates, et cetera. And then lastly, I just want to end on knowing your team, since this is a great place where when you do QI work, when you do process maps, you suddenly realize like people are like, oh yeah, I could do that. I should be doing that. And I think it's something that, we switch jobs or, go from fellowship to faculty practice and suddenly have a whole different team. And no one really, like very often we don't really learn how to work in that new team. And I think QI is a really great opportunity to kind of focus you into that.
Great. Thank you. So we have like 2 minutes for questions, and then we'll do the last talk. Any urgent questions from the audience? It's a great summary. Thank you. All right. With that, we'll turn to the last presenter then. So this will be Dr. Breidbart from NYU, who's going to speak about adjunctive treatments in type 1 diabetes.
I'm going to try to do it without the microphone, but if you guys think I need it.
You'll need it for Zoom. So.
Oh, I'll need it for Zoom. Never mind. Okay. So I'm Emily Breitbart. I'm at NYU, where one of the tours is after this. And I was given the task to talk about adjunctive treatments in type 1, kind of a historical perspective, and then also looking forward for some of the treatments. I think a lot of us probably use adjunctive treatments without even really thinking about it. Should I use the... Okay, so the goals of adjunctive treatments are going to basically control the metabolic state of people with type 1 diabetes without increasing weight gain, which, as we know, intensive diabetes management with insulin often can offset the benefit of strict glucose targets and increase cardiovascular events. Interestingly, in one of the DCCT studies, when they actually they had the intensive insulin management patients in the first 13 years, those patients in the intensive group actually had lower cardiovascular outcomes. And then after 13 years, they actually aligned more with the conventionally treated group in terms of cardiovascular risk factors, likely due to the weight gain. And then the analysis of both the type 1 diabetes exchange and the prospective diabetes follow-up or GPV registries, which are in Europe, revealed that up to 5.4% of type 1 patients are using non-insulin anti-hyperglycemic agents in addition to insulin. So I'm highlighting, these are the 4 that I'm going to be highlighting in the talk. The first we're going to start with is amylin, and I'm going to just preface this by saying that some of the names of these medications are pretty hard to pronounce. So amylin is pramlintide. And basically the way that pramlintide works is it's co-secreted by with insulin by our beta cells, and it has 4 sets of action that synergize with insulin to reduce our postprandial excursions. The first is it enhances postprandial satiety. The second, it reduces dysfunctional glucagon secretion by the pancreatic alpha cells. The third is it delays gastric emptying. And the fourth is it reduces hepatic glucose production. So interestingly, this is actually the only adjunctive therapy I'll be talking about that has been FDA approved for use in type 1, and it was approved in 2005. It's shown to lower A1C by about 0.5%, a very mild weight loss of about 1 kilogram across studies. The reduction in total daily insulin is about 6 to 12%. A main issue with this is postprandial hypoglycemia. And despite approval in 2005, few patients were on it because what it does is it requires 3 to 4 additional sub-Q injections a day in addition to insulin. Okay, so patients who have to basically inject both therapies prior to eating a meal. And it's also very expensive. So there's been a very low uptake of this. More recently, there's actually been exploration of the co-formulation of insulin and amylin to see if that could reduce the number of injections, but so far, that's still in study phases. The second thing I'm going to talk about is metformin, which obviously many of us are very familiar with because it's a cornerstone of type 2 management. Basically, as many of us know, in type 2 diabetes and diabetes in general, it reduces hepatic gluconeogenesis. It decreases the breakdown of glycogen and increases our insulin-mediated glucose uptake and sensitivity. And metformin, not surprisingly, was the most commonly reported medication in both the type 1 exchange and DPV registries. 3.5% and 1.3% respectively were on metformin in those groups. Okay, so metformin is actually licensed in France for type 1, but it's used off-label elsewhere frequently. And there's been a few trials that are worth mentioning. So there's a type 1 exchange trial that Dr. DiMeglio was on in 2015. This was published that looked at adolescents who were overweight and obese. And they saw that they had modest reductions in insulin requirements and weight and transient A1C change that wasn't sustained, which I'm actually going to have some slides after this that are going to show that. Mostly, though, the authors ended up not recommending treatment because there are multiple secondary endpoints in the study weren't proven to be statistically significant. The only things that the findings that favored metformin were really insulin dose and measures of adiposity. And there were significant GI side effects among the adolescents in the trial. So ultimately, they didn't support the use of metformin. There was a removal trial, which was a placebo-controlled trial in adults that was basically powered for a cardiovascular outcome. They measured as the primary outcome carotid intima media thickness, which is really a good marker of atherosclerosis. They did not find any difference in that. They did see a very small weight gain, a small reduction in LDL, a 2 unit per day insulin reduction, but only a 0.13% A1C lowering. And lastly, there was a CLAMP study that was done in 2019, published in 2019, that looked at 3 months of metformin, and it significantly did improve whole body peripheral insulin sensitivity in youth who were overweight or obese with type 1. But again, A1C, really no impact on overall A1C. So these are slides from the type 1 exchange study, the one that I measured first. And you can see here that At 26 weeks, the mean total daily insulin dose per kilogram was lower in the metformin group versus in the placebo group. So this was statistically significant. It was 23% in the metformin group versus 1%, and had a reduction of insulin doses. And then in this group, they also looked at change in BMI, and you can see here that more participants in the metformin group had a reduction in body weight of at least 5% from 10% from baseline to 26 weeks, and less people in the treatment group had an increase in weight in the study as well. And lastly, this was sort of the most interesting finding about A1C. So in the first 13 weeks, there looks to be a little bit of a difference of change in A1C versus the metformin group we can see is lower in the blue versus the placebo group. But by 26 weeks, both A1Cs in both groups increased about 0.2% from baseline. So there was not a statistically significant difference in A1C. So that brings me to SGLT2s. And these are very hard to pronounce. So I think it's like dapagliflozin and then et cetera. But basically, these work by reducing glucose reabsorption in the proximal tubule. So basically, you increase glucose excretion in the urine. And it actually also, by doing so, you lose about 200 calories per day in the urine. So I'm going to just sort of skip pronouncing the names, but these two are licensed in Japan. And in Europe, dapagliflozin was actually approved in overweight people with type 1 with suboptimal glycemia in 2019, but then withdrawn in 2021 by AstraZeneca. And AstraZeneca said that the decision wasn't motivated by safety concerns, but they did point to the fact that, well, we'll talk about this, but there is this increase in DKA, and we don't want that to be confusing to physicians when they're prescribing it for other things. So in any case, it was out for about 2 years. It has not been approved in the US for type 1. So there's been about 8 double mask clinical trials in type 1 diabetes for SGLT2s, which are widely used in type 2. So the first is the DePict trials, and they showed a reduction of A1C up to about 0.36% with weight loss of up to 3 kilos. Then there's the EASE program, which showed a reduction of A1C up to 0.5% with modest to high doses of the SGLT2s. And they saw a reduction also in total daily insulin doses of up to 13.1%. There was the Tandem 1 and Tandem 2 studies, which showed a significant increase in total time in range on CGM, which was up to 12.7% in the higher doses. But interestingly, in these studies, they saw that the A1C lowering was actually greatest at 24 to 26 weeks and waned by about 0.1 to 0.15% at 52 weeks. And the most weight loss had actually also occurred at the point of the 24 to 26 weeks. And it's hypothesized that because there was initial loss of calories through the urine, that the body had a compensatory increase in food intake. So people ended up increasing what they were eating in order to counterbalance the weight loss. And so that's why it kind of dulled the effect by the 52-week point. This is actually a figure that's showing these 3 of these main studies, 4 of the clinical trials. And you could see here that the greatest efficacy in glycemic control was seen at 8 weeks, and that it progressively weaned over time. And again, this is likely due to what we just talked about, but there weren't any studies that really went beyond 1 year of therapy to see what happened. And this is a table. It's kind of hard to see from here, to be quite honest, but I'll talk about it. But basically, it shows that in all 8 clinical trials, the SGLT2 treatment increased the risk of serious ketoacidosis, and the average proportion of patients throughout all the studies that did have DKA was about 0.6%. So euglycemic DKA is really what's we worry about with SGLT2 inhibitors, because there's still an absolute insulin deficiency, but your glucose can be normal because you're losing it through the urine, and that can lead to a delay in detection. So you can have pretty normal blood sugars, but still be in DKA. And as I said before, so the proportion of patients with DKA was 3.5% in lower dose SGLT2 groups and 3.6 in higher dose groups, compared with 0.6 placebo. And the significant rates of DKA have prevented the widespread uptake. There's also an increase in GU infections as well, or in urinary infections, which makes sense when you're having that glucose load in the urine. The FDA did some models to predict, and they predicted about an additional case of ketoacidosis for every 26 patient years of treatment with SGLT2s, about 16 deaths per year for every 100,000 patients treated. So without the robust evidence that SGLT2 inhibitors will provide sustained glycemic effect over the long term, at this point, we don't really have good cardiovascular renal data either. So for currently, the risk of DKA is thought to sort of outweigh the benefits that we know of. But future research is really needed to see, well, what is the optimal way to test ketones? And if we put patients on this, is there a way to, or frequency we should be testing ketones in order to catch DKA and prevent it? And again, like I said, what are the cardiovascular and renal outcomes? And if are those so beneficial that they may outweigh the risk of DKA? Lastly, we have GLP-1s. So, I mean, as many of us probably know from prescribing these for type 2 diabetes or for obesity, there are many effects, increasing satiety, increasing our insulin sensitivity in multiple ways. But actually, and interestingly, the efficacy in type 1 diabetes actually appears to derive more from the reduction of glucagon secretion than anything else. So meta-analysis have shown that these have reduced prandial and basal insulin requirements in type 1 diabetes. There was the adjunct trials that showed that GLP-1s reduce body weight in patients with type 1 diabetes. Liraglutide reduced body weight by 4 kilos, and exenatide reduced body weight by 8.3 kilos. The A1C reduction was modest, with liraglutide or Victoza having the largest change. And actually, interestingly, C-peptide positive patients, so those sort of early in diagnosis, had the highest A1C decline. There's limited data for long-acting agents. There was one study I found that was just published this year that looked at longer acting agents, and they saw increased time in range. They saw a decreased 14-day average blood sugar by 19 milligrams per deciliter, a decreased 14-day blood glucose standard deviation. They saw a decreased incidence of DKA hospitalizations, although in the next slide, that was not necessarily seen in the short-acting studies. And they saw a decrease in weight. And there was actually a study, I don't know if any of you saw this in the New England Journal a couple of days ago, that the cardiovascular benefits have now been shown to be quite significant, even in people who don't have type 2 diabetes on Ozempic. So there would be sort of no reason to think that doesn't, qualify for type 1 also. Hypoglycemia was increased in GLP-1s, but compared to SGLT2s, much lower. And the odds of severe or symptomatic hypoglycemia were not significantly elevated. The short-acting studies for GLP-1s did show higher rates of ketosis, unlike that one Ozempic study. And they thought this was likely due to GI side effects of the drug, so vomiting, potentially decreasing insulin, because many practitioners will decrease your insulin preemptively when you go on a GLP-1. Also decreased oral intake may have contributed. But again, like I said, it's a very much lower risk compared to SGLT2s. There's current trials going on now to start to address the micro and macrovascular outcomes of GLP-1s in type 1. And, I don't know for all of you, but I certainly have patients with type 1 on GLP-1s, and it'll be very interesting to sort of see what the actual data shows. So this is sort of in summary. So, amylin, despite FDA approval 18 years ago, there's really just been poor uptake amongst endocrinologists, and it's really not used very often. Metformin, obviously we know is very safe. It's commonly used, but there's mixed data on really the long-term A1C effects. SGLT2s meet many criteria for what would be considered to be ideal adjunct therapy. but there are significant concerns of ketoacidosis, which I know in someone who practices pediatric endocrine, that's obviously a huge concern. And GLP-1s have some early convincing evidence, but really more studies are needed to see if this is going to also become a mainstay of our care for our patients. That's it.
Thank you. Any questions about this or others? We got a couple. Actually, do you want to take the microphone?
Yeah, sure.
We have about 3 minutes for questions. Well, we do the Zoom. Yeah.
I was just curious, do you know if there was any incidence of pancreatitis on the GLP-1 groups?
So no, I didn't see any increased incidence in the type 1 trials versus the type 2 trials. So it didn't seem like there was an increase amongst those with type 1 comparatively to what we know is already going to be a slightly increased risk.
Do you know in the SGLT2 trials, the people who got DKA, did they have a greater insulin dose reduction? It looked like 6%, 6 to 10% overall, but were there differences in the people who got it?
So they didn't, to be quite honest, I'm not sure. But I don't think there was a difference in the dose reduction of those who had greater DKA events versus those. In some of the trials, they automatically decreased the dose, like they preemptively decreased everyone by, let's say, 0.2% on their insulin doses, and then they would titrate them up as they saw how they did on the medication. So they did try to do it in a very, they had a sort of an algorithm of how they were going to go about doing that. So it was, a randomized trial as opposed to sort of doing that and retrospectively.
Thank you. That was great. Are you having any issues getting GLP-1s covered?
Good question. So I'll go back to the front of the room, but in New York, yes, Medicaid does not cover GLP-1s in general for obesity. Now for type 2, they do. So for type 1, if it's a Medicaid-based insurance, then it's very hard to get it covered. It really has to be, obviously a kid who's overweight or obese and would qualify for a GLP-1 due to their weight. So it's very much based on whether their insurance would cover it for weight. And it has really kind of nothing to do, like their approval of the agent has nothing to really do with their diabetes status. It does for us, but it doesn't necessarily for like when we're applying for it. So it really depends on if you have good commercial insurance that's going to cover it, or if you have not insurance who just completely does not cover GLP-1s at all for weight. So it's not, I would say like our rate, if I had to say, would probably be like 60% denied, 40% approved.
Okay, I wanted to just quickly pull the room too with this last, I just want to show of hands of how many people have either used themselves or prescribed to amylin to somebody with diabetes. So a few. What about the SGLT2s? Not metformin? I think that's probably the biggest uptake. Okay, and then what about the GLP-1s? Okay, so I think that's helpful. I think it'll be interesting to pull data out of the registry in the future. And, but I want to thank all 4 presenters for some interesting talks. I have some great notes and for sharing with us today. And with that, I think Nicole will tell us where we head next.